the meeting for posting. So for Epilepsy iConnect at home, it's advised that you type into your browser or click on that link that is listed on the top line, https://global-gotomeeting.com join, and then that linkage number, which is only good for this particular program. If you don't have a computer, you can phone into the phone number 571-317-3122, access code 335-819-557. However, you will not see the slides or any webcams. Now, during the introductory talk, your microphones are all going to be on mute. And during the talk, we're going to pose some questions, and I would like for you to type your questions into what's called the chat box. So all of you take a moment to locate two things. One is the icon by which you turn your microphone on and off, and the other is the chat box into which you can enter your message. After Dr. Cornes is done talking, I will organize some of the questions that have come in via the chat box, and then we'll unmute you as you wish in order to have you ask your questions. I'd like for you all to consider sharing your thoughts and experiences with each other and not simply pose questions to the presenters, to the doctors, although those are all right as well. The session is being recorded for posting on YouTube and elsewhere. So if you wish to be anonymous, don't use a webcam and log in with a fake name. Or if you want to be completely anonymous, you can simply type into the chat box a question or comment, and I will read it. I do want to emphasize that we want you to share your thoughts and experience, but this is not a medical web consultation, so please don't present your full medical history because we can't give individual medical advice. We're talk show hosts in this roles, although in our other identity we are real epilepsy doctors, but not here. This is educational. And also, I would ask you when you ask questions to please try to keep them brief, and forgive me in advance if I interrupt if the question is getting too long, so we can give others a chance. So at this point, I will turn the program over to Dr. Susannah Cornes, and I'll rejoin you after the presentation. Dr. Cornes, it's up to you now.
Thank you, Dr. Fisher, and I'm so pleased to be here today with you all, and look forward to getting to hear from you momentarily. So my topic for today is wellness and epilepsy, and I thought as we begin it might be nice to just take a look at that history of the word wellness and the meaning. As I'll get to, it's a very common word today, but that wasn't always the case. It was coined by the father of the wellness movement, Halbert Dunn, in the 1950s in a series of lectures, and then he published a book called High Level Wellness in 1961 that was apparently picked up, according to an article in the New York Times, by a Dr. Travis for $2 on the clearance rack at a bookstore. And Dr. Travis was taken by this idea of wellness, which he went on to define as a self-directed approach to well-being as an alternative to the traditional illness-oriented care of physicians. So this idea that we can individually seek out wellness in our lives. And he formed a wellness resource center here in California in Mill Valley, which was the first wellness center. Dan Rather covered this wellness movement not too long thereafter in 1979, and when he covered that on 60 Minutes, he said, well, wellness, there's a word you don't hear every day, and now that's probably not the case. When you Google wellness, there are 389 million returns, including, as I've shown here at the top, wellness dog food. So wellness is extended very broadly into our environment and is defined as a state or condition of being in good physical and mental health. And mentioned right at the top is, when you come right down to it, stress affects every aspect of wellness. So in thinking about this general topic today, I wanted to begin with a discussion of stress and to get to whether it's important in epilepsy. And to define stress, it's a condition or feeling when a person perceives that the demands on them exceed their personal and their social resources. The connection between stress and seizures is challenging, I think in part because many people, as we'll discuss, experience stress before their seizures. They think of it as a trigger for their seizures, and I'll be curious to hear from you all whether that's the case for you. Also, seizures can create stress, and so there's a bi-directional relationship going both ways. So as one of our first question today, I invite you to comment in your chat box, which you should see there on your screen, whether stress affects your seizures, either the frequency or the intensity of your seizures, and we can come back to some of your ideas on that. As you're thinking about it, I imagine that in your own individual lives, you're thinking about some of what is depicted here. And this slide shows that each of us has a seizure tendency and a seizure threshold. And the threshold is a theoretical line beyond which, when we're pushed, we can have a seizure. And we all have this threshold. In people that have seizure disorders or epilepsy, the idea is that that threshold is lower, and factors like alcohol or menstruation, missed medications, stress and illness might push you over the threshold and make a seizure more likely. But over time, the relationship between all of these variables can be very hard for us to individually track and hard to study. When we ask patients what types of feelings or factors trigger their seizures, they, by many studies, mention stress and stressful life events as the #1 trigger factor. But there are many others. I've listed a few here, like sleep deprivation, menstruation, missed medications, illness, alcohol, maybe flashing lights. And now I would invite you all as well to type in triggers for your seizures, things that you have noticed, again, that we can circle back to for discussion. Going back to some of those questionnaires for patients who have seizures, when you ask them about trigger factors and divide them into patients who feel that stress triggers their seizures, which is shown here in this orange rectangle, or those that feel that stress is not much of a trigger, it makes sense that many of the people who feel that stress is a trigger have tried to reduce their stress. This shows that over 50% or over half of them have tried stress reduction. And that's compared to maybe about a quarter of people who don't feel that stress is much of a factor for them. It's interesting, though, that regardless of whether folks felt originally that stress was much of a factor, the great majority of both groups felt that stress helped to reduce their seizures when they did try stress reduction. This still doesn't completely answer the question of whether stress caused the seizure when we think about that original diagram of the relationship between stress and epilepsy, because there are some things that are different between people who feel that stress is a trigger for seizures and those who don't. The people that feel that stress is a trigger are at a higher risk for depression and anxiety, and they're more likely to report difficulty feeling irritable or tense or restless or impatient, or that things are a struggle. And it may be then that anxiety is a characteristic that leads individuals to link seizures and stressful experiences, or it may be that stress increases the seizure risk and that anxiety is a seizure precipitant. So to get at some of these questions about the relationship, investigators have done a number of studies, and I've just very briefly summarized a few of those here.
Susannah, may I interrupt for a moment? I have one of the viewers who says that they cannot see your slides. They can see your picture. Now, I can see your slides, so I'm not sure why that's happening. If other viewers are not able to see the slides, unmute yourself and tell us, or put it in a chat box. Okay, so I'm seeing that others can see the slides. So Valerie, I'm not sure why you can't see the slides, but I apologize. It must be
Yeah,
something local
I
that
see
you're at.
both of you in a split screen, actually, and I'm not sure if there's a setting to access a different view, but okay,
It's
sorry to
local to
interrupt.
you. It's local to you because the slides are being broadcast. So please
Okay.
continue, Susannah.
No problem. So looking at how investigators have tried to understand the relationship between stress and seizures, one way is by collecting diary information in which individuals make notes regarding their stress level and whether or not they are having seizures. And the couple of citations or references here at the top of this chart are of research that found that daily stresses and anxiety were associated with an increased risk of subsequent seizure in that next day. Other folks have gotten at this question a bit differently by looking at populations of individuals who've had major stressful events or combat exposure, for example, or looking at ER visits following natural disasters and finding increased seizures during those times. For one of the investigators that looked at the seizure diary information, they were able to look at that subset of patients, about 20% of their patients who felt that they could predict their seizures based on stress, anxiety, and lack of sleep. And this is a little bit of a confusing chart potentially for some, but let me just walk you through this. In the lavender color, you can see, if we just focus on that, that as people felt that seizures were extremely unlikely to when they thought they were extremely likely, the chance of having a seizure rose from being maybe about 10% all the way up to about 40%. So some folks have some ability to predict if a seizure is likely based on some of these feelings such as stress and anxiety that they are having. Now, 40% is still less than half, so most of the time a seizure didn't happen, but they had some ability to predict. And why is this important? Well, it's the sort of thing that maybe could be harnessed in some way to make sure folks are safe or even to prevent a seizure just before it occurs. But we're not there yet. Interestingly, in other questionnaire data, when you ask patients what they do when they feel a seizure coming on, folks are trying to take advantage of these moments when they feel they can predict a seizure to do a whole variety of different interventions, from drinking water to touching a cold surface or going and lying down in order to try and stop the seizure. And there's not much known about whether these things help or not, but we certainly hear this from our patients. When we try and look at what we can study to see whether these interventions might help reduce seizures, the things that folks have focused on, rather than that list of all the stuff that our patients are doing, are these stress reduction techniques like quiet sitting, yoga, meditation, and progressive muscle relaxation. So I'd like to invite you all to, again, type down in your chat box, are there things that you are doing to reduce stress? You might also type down things such as what I showed a couple slides ago that folks might do to try and prevent a seizure, anything that you're doing, but particularly stress reduction to help your seizures. So studies looking at these interventions, I've summarized for you here: progressive muscle relaxation, quiet sitting, contingent relaxation, biofeedback, yoga, therapy. These are all things that have been looked at least in small studies, have been associated with a reduction in seizures and often an improvement in general measures of quality of life. Unfortunately, we're still waiting on bigger data from larger, well-controlled trials. So what are the take-home points for right now on stress and epilepsy? Well, we can say that several interventions to reduce stress have been studied and they may be useful. They tend to enhance well-being and they may reduce seizures. We need more data, but we can also say that it's unlikely that these interventions will cause harm, and many patients do perceive a positive impact on their seizures. So I'd like to change gears now and look at some of the other activities that might contribute to wellness. And I picked diet and exercise, but you can imagine there are other variables as well, from community to relationships, hobbies, family, spirituality, other self-care, and the list could go on, that might contribute to wellness. I picked diet and exercise because I get asked about these by my patients, and so I'd like to briefly touch on them. Diet is a big topic and may be covered more later, but for today, I'll spend a few slides on this. And I'd like to particularly point out ketogenic diet and modified Atkins diet. Ketogenic diet was the mainstay of epilepsy treatment in the 1920s and 30s. And this is a diet that uses a 4-to-1 ratio of fats to carbohydrates and protein, or sometimes a 3-to-1 ratio. And it has been found and well established to be very effective, particularly in kids, but more recently in adults. The response rate, meaning the percentage of patients that have a greater than 50% reduction in their seizures on the ketogenic diet, is almost half, about 44%. So it can be very, very useful, particularly in people that are having seizures despite maximal medical therapy. The modified Atkins diet is somewhat similar. It's at least similarly effective, it seems. It's less restrictive in terms of fluids and calorie limitations, and you can have more protein and not have to weigh all of your food. The ratio that it uses is a 1-to-1 ratio of fats to carbohydrates and proteins. And the response rate, again, meaning the percentage of patients that have an over 50% reduction in seizures, is maybe about a third. These are some examples of what meals from the ketogenic diet and the Atkins diet might look like, and you can see they're somewhat similar. There's a portion of meat and vegetables. There's no pasta or fruit. It's going to be low on carbohydrates, as we mentioned, but both of these look reasonably palatable, at least to me. The largest study in on the modified Atkins diet in adults, which I thought might be relevant for us to take a quick look at today, was this one that I've summarized here. And in this study, they did it in the context of a larger study, but basically there were over 100 people who had seizures despite maximal therapy that were adults and that were tried on the modified Atkins diet. And about a third of them had a reduction of greater than 50% in their seizures, and a small percentage became seizure-free. And importantly, over time, patients were not worse, so the risk was low. There are other diets that people might consider. Low glycemic index diet is one in which 60% of the calories are from fat, and so the carbohydrates, again, are a little bit more permissive. And there's some data that that can help. Medium-chain triglycerides make use of types of building blocks that yield more ketones, and so you don't need ultimately quite as much fat for this particular diet. Gluten-free diets I'm asked about occasionally, and there's some data that those help in people that have celiac disease, but that will be a small percentage of our patients overall. And then patients sometimes try vegan, vegetarian, or other diets that they feel help, and there's not a huge amount of data on those. But individually, people may feel a benefit from that. Overall, the pros and cons of using diet to treat epilepsy, well, On the plus side, it's a non-medication option, which can be appealing to some people and may have the potential for fewer medication side effects as a result, and it works pretty quickly within days or weeks and can reduce seizures. On the negative side, it requires resources, and so in order to really think in detail about these diets, you need to connect with a dietitian. It may be difficult to follow some of the diets, and many of the studies found about half of the patients would eventually give up on the most restrictive of these diets. And some patients feel that they're just not palatable, or they feel inconvenienced by the need to do more frequent visits and monitoring. There are some side effects. The most frequently noted side effect is high cholesterol. So some people won't want to do these diets if they have certain medical conditions that they wouldn't want to worsen, like high cholesterol. And the other ones listed here: constipation, weight loss, dehydration, kidney stones, and less commonly pancreatitis, low bone density, or gallstones. So there are a number of sort of infrequent but potential side effects to consider with your doctor. So I'd invite you all to mention in your chat box again if you've tried a diet for your epilepsy and how did it work. Again, we want to try and harness your collective wisdom as much as we can while we have this hour together today. And finally, in the last few minutes, I'd like to look at exercise. This is a photo that I took from epilepsy.com on a section called Safety with Exercise in Sports. As you can see here, there are lots of different ways to get exercise. You all may have more ways of exercising to add to this list. I mentioned running, walking, weightlifting, biking, swimming, dancing, but there are many ways. If you've tried a type of exercise with treatment of your epilepsy in mind, we'd love to know what you tried and how it worked. So what can we learn from any literature on how exercise affects people with epilepsy? There are some laboratory studies that have found that exercise may reduce seizures and help healthy connections form in the brain. And in people, they've done weeks of exercise programs, in an experimental trial where they compared exercise to no exercise, and it looks as though the exercise does improve quality of life. It's harder to show that there's an impact on seizures, but it does have an improvement in quality of life at the least. There are some rare reports of seizures precipitated by exercise. And this is very uncommon, but can occur particularly in people that have what are called reflex epilepsies. And those are types of syndromes in which seizures can be triggered by environmental stimuli like steam or eating, but that would be fairly uncommon. So to the question of whether exercise is safe in epilepsy, the International League Against Epilepsy called a task force to provide some input in this area. And one of the reasons for that is because they felt that exercise has a positive impact on self-esteem, socialization, long-term health, and that people with epilepsy might be advised against sports due to fear or overprotection or lack of information. And so the committee attempted to provide some general guidance concerning participation in physical exercise and specific sports for people with epilepsy. And what they did was they broke down exercise into 3 categories. The group 1 types of exercises are ones that don't have a significant additional risk for people with epilepsy. And these are a lot of the most common sports, like the team sports on the ground: baseball, basketball, running, dancing. Group 2 sports were ones that had some potential for risk for the individual with epilepsy, but not so much for the bystanders. That might have been downhill skiing or canoeing, gymnastics, types of exercise, again, in which were a seizure to occur, there could be some risk to the individual. And then the group 3 sports were considered the most risky for people with epilepsy and in some cases for bystanders. And those would be things like aviation or climbing, diving, or particularly scuba diving. And these were considered, again, the most risky. And then they put forth in their paper some considerations regarding sports and epilepsy with the acknowledgement that these things may be added to and revised over time. And their considerations were that when folks are thinking about exercise and epilepsy, they should think about the probability of seizures, the seizure timing, the type and the severity of the seizures. For example, whether or not the seizure might impact awareness, seizure triggers and attitudes of the individual and potentially coaches and other folks leading the exercise regimen. And then finally the type of sport with regard to the different categories that we just reviewed. So a category 1 sport would generally be okay without additional risk. Category 2 or 3 would require a little bit more of a discussion with the doctor and consideration for a waiting period of possibly a year without seizures or 6 months after reducing or stopping medications, but again in conversation with your doctor. So I'm just about at the end, and I, as my final slide, just wanted to bring up what is the impact of exploring these environmental variables that affect seizures like stress reduction, diet, and exercise. And I would consider the potential for exploring these variables to have a positive, to lead to a positive lifestyle change, to lead to changes that might improve mood or create a sense of empowerment, that might reduce seizures, and that can increase overall health, and ultimately going back to that idea of wellness. And I will wrap it up there and invite everyone to type in questions and potentially turn it back over to Dr. Fisher.
Okay. Well, thank you very much, Dr. Cornes. Don't go away. I'm sure there'll be some questions for you. I believe that most or all of you have been able to scroll through the chat boxes, except for a few private chats, mostly about getting audio and the like. But we've had a good response to the request for comments and questions, and let's take them group by group if we can, starting with the issue of seizure triggers, stress potentially being a trigger, and what some people have been able to do to reduce the stress level and perhaps help their seizures. I noticed that Kelly, Karen, Todd, Patty all said that stress did affect their seizures, and several of you did list some triggers. For Ginny, lack of sleep, same for Todd and Kelly, illness in addition. Not eating well, hormones for Patty. So let me unmute you all, and then any of you who care to comment on triggers for your seizures and what you do about it, just go ahead and speak up. If you want to use a webcam, you can, but that's optional. So all should be unmuted, although you will have to unmute yourself locally.
So Dr. Fisher, this is Patty.
Yes, hello, Patty.
Hi. So I would ask Dr. Cornes and you, have you noticed the difference if a person has one or more triggers at a time? So the way I think about it is that, well, one may increase your likelihood to it. It's for many people, it's when multiple things happen at once, particularly if it's during a high-risk time. So for a woman, if they're premenstrual or during ovulation, you know, that's when the sleep deprivation may affect them more, where at another time, when they're not hormonally sensitive, that might not be a factor. And I'm just inquiring about your thoughts on that.
Dr. Cornes, I'll assume the questions are to you, and I'll occasionally chime in.
I think that that's a very fair point. I frequently review with my patients a variety of different variables in parallel when somebody has a seizure. Not only how much did they sleep, but did they miss any medication in the days leading up to that? Was there stress as well? Was there any illness at the time? Were there other disruptions related to travel or change in time zone that could have disrupted sleep even further? A whole range of things. Menstruation, you mentioned. And I had shown that slide early on of this idea of a seizure threshold over time, and I think it's true that there are lots of variables that are likely to play some role, and there may be a situation of a perfect storm sometimes. And that makes our job tracking these variables a bit more challenging because they may all be interacting with one another.
Would anybody like to comment on things you do to reduce stress? Several suggestions came across in the chat box. Just unmute yourself and start talking.
Hi, Dr. Fisher and Dr. Cornes. My name is Tad Texer. The things that help me to relieve stress tend to be journaling, yoga, which I consider exercise, and prayer. Things of that nature tend to be helpful. And then if I have I was diagnosed with juvenile myoclonic epilepsy, so if I have like a myoclonic jerk, that's an indicator for me to go and lay down. So that reduces the stresses. Go to a safe place.
I noticed that several people also listed music as a way to reduce stress.
Yeah, I do that as well.
I guess it depends upon the type of music. For example, my stress level goes up with country music, but that's just me.
I'm glad you mentioned journaling as well, because one of the studies I was involved in used journaling for what's called our placebo arm. And the placebo arm is the non-active arm. So we were comparing progressive muscle relaxation to another group of patients which did journaling as part of their intervention to reduce seizures, but it was supposed to not work, and then both groups got better. So it made it harder for us to show that the progressive muscle relaxation worked, but I think it points out that there are very many different ways to reduce stress.
Would you say what
one thing too that they've come out with, and that I've seen are those like adult coloring books, and they have that. They don't have it in my town, but they have eStudio, the eStudio for like art therapy, and I think would be an interesting thing to explore too.
Yeah.
Art and music, it kind of all goes together.
Yes, and I see there's a question from Valerie about whether music is helpful in regulating anyone's wave patterns. I'm not sure if that's wave patterns refers to the wave in Dr. Cornes' slide of waves of triggers that may add up to a seizure, or whether you're asking about brainwave patterns, EEG. There is something called the Mozart effect that may relax people, but it's controversial. Still, I think music has been a very good source for some. So Patty had asked a question: could stress affect some seizure types more than others? I myself don't know the answer to that. Do you, Dr. Cornes?
Yeah, that's a great question. I don't know that. I don't believe we know the answer to that. I'm thinking, a lot of the studies have looked at what are called focal epilepsies, and those are the types of seizures that start in one region rather than starting generally or engaging both sides of the brain rapidly. And I don't know at studies that have divided the investigation according to seizure type. I think we're still stuck at really proving that stress reduction helps generally.
Right. In work that I've done before, that's the same thing, is that the studies haven't been large enough to be able to break it down into seizure type. But to me, it would make sense, you know, if you're dealing with areas of that are involved with emotions, that they might be more susceptible to buildup of emotions or stress. You know, we do know that in women, I think those with hormonally sensitive seizures, there's fair amount of data saying that they may be more susceptible to then changes in seizures around their periods, but it's not 100% there.
Well, and I also think that Tad's point about juvenile myoclonic epilepsy, that we think of that as starting broadly, but sometimes folks will have these warnings of sudden jerks, and that may be another, it may be that, as you mentioned, if emotional regions are involved, maybe that leads us to think that regulation of stress could help. I think also when people have these warning periods, whether it's from juvenile myoclonic epilepsy or other epilepsies that have more of a pre-ictal state, then maybe that would also give us an opportunity to intervene with stress reduction. Yeah, I'd love to know more about the answer to that.
There's a question about whether high altitude provokes seizures.
Yeah, I get asked this occasionally, and when I go to look up information, you know, there are reports of people having seizures at altitude. I haven't been able to discern a real, you know, percentage risk or really well-controlled information. So my approach has been that if people have had seizures at altitude, if they have a concern about it, we might talk about, you know, an emergency medication that they would have, or an approach, an action plan. I think the majority of folks are able to, you know, get on a flight without any incident. I don't know if you have anything to add to that, Dr. Fisher.
No, it's certainly the case that if oxygen levels get very low, you can have a seizure, but barring some kind of catastrophic malfunction, on an airplane flight, typically you're at an altitude of air pressure of about 5,000 or 6,000 feet. It's not low enough oxygen to provoke seizures. And even on high mountains, 10,000, 12,000 feet, oxygen should not be a factor. So what you're talking about is altitude and perhaps the low oxygen being an individual trigger. One thing to say about triggers is there are common triggers. Probably the most common are missing sleep, missing your medicines, menstrual cycle in women, being physically ill, very high levels of stress, sometimes precipitants in the environment, of which flashing lights at certain frequencies would be the most common. But there is a huge list of individual triggers that people have as well, and it seems to be very much linked to them. So some may be triggered by heat, others may be triggered by cold, or unusual stimuli. Thinking certain thoughts sometimes triggers seizures, eating certain foods. So this can be quite individual, but it's really a good thing if you can identify triggers, because then you can avoid them. So let's move on now to the subject of the diet. Several of you have...
I'm sorry to interrupt, but I just want to tell you that was so encouraging to hear, because when I get really hot, I feel terrible. So thank you for that. That was a gift. I appreciate that.
Sure. So let's move on to the diet. There are a couple of questions and some comments. Tad had a question about whether there's any data on vegan diets being helpful or, I suppose, harmful for seizures. Melissa asked about whether essential oils can have an effect, and I think there was a little chat dialogue going on about essential oils. So, Melissa, if you're still there, would you like to comment on your diet experience or questions? No? Okay. One of you had tried the ketogenic diet. Would you like to share your experience with the keto diet?
Hi, yes, it's my son who has epilepsy, and we tried it as a family to be supportive of him. He's 22, and found it to be challenging, mostly because we didn't have a dietitian, to support us. So we were, other than following recipes, we were a little unfamiliar with if we were doing the right thing.
Did you want to respond to that, Dr. Cornes, or would you like me to?
I'm sorry to hear that it was challenging, and I think you're certainly not alone. I think that issue of meeting the appropriate support system in order to try these things is a big challenge. I think when folks get serious about trying a diet like ketogenic diet or modified Atkins diet, being able to connect ideally with an epilepsy center that can at least get you started with an initial visit with the dietitian to discuss it is incredibly useful. And I imagine that sometimes that's just not possible depending on where folks live and what the resources are.
There's a national resource called the Charlie Foundation, named after the son of a famous Hollywood director. And they can provide a lot of good information for you if you look them up on the web. But there's nothing that substitutes for having direct personal interaction with a dietitian. It's extremely hard to do the ketogenic diet if you don't have a dietitian, because it's not like a weight loss diet where if you fall off the wagon you just get back on and try harder the next day. You may have to change the pills that you're taking because they may have too much starch or carbohydrate in the pills. You may have to change your toothpaste. It is potentially very severe. The Atkins diet, much less so, but ketogenic diet virtually requires an experienced dietitian.
And thank you for mentioning the Charlie Foundation, because I meant to say as well that in my slides the pictures of the meals are from the Charlie Foundation website. So you can go there and find a lot of information on recipes and other resources.
We have been there, and that was helpful also. We've just recently connected with a Mayo Clinic where they probably do have a dietitian. And we went to a conference where
they invented the diet in the 1930s. Continue.
Yeah. We went to a conference where they had a vendor there that provides products that are keto friendly, and they were actually very good, like little donuts and pizza. And I know that the Keto Foundation has an annual conference. I think this year it was in Canada. So, I mean, those kinds of things can be, I know not everybody can get to those places, but it's another option to get information.
There's a question from Karen about low fat. Karen, would you like to pose it, or if not, I can read it for the group? Okay. Well, Karen had noticed that a high-fat diet might be beneficial for seizures, so she asked the converse. Does a low-fat diet provoke seizures?
For my part, I'm not aware of any research on low-fat diets making things worse. That's an interesting question. I mean, I think, as a practitioner individually, I'll have folks come to me with personal stories of things that have helped, you not having a huge amount of sugar all at once, or these other kinds of more minor interventions that might impact their seizures. I'm not aware of controlled studies looking at that.
Me either. And
might have other benefits.
I don't think that it's likely to be a problem, because the key in the ketogenic diet is not high fat. It's low carbohydrates. It's by taking such low carbohydrates that the brain no longer has sugar as its primary food. Normally the brain just eats sugar, believe it or not. You're converting all of the other things you eat to glucose as the brain's energy food. But when there's insufficient carbohydrate, it can't do that, and it starts burning proteins and fats to make ketone bodies as the brain's energy source. This happens about 4 or 5 days into the diet, sometimes 3. And the ketone bodies, the so-called ketosis, has a poorly understood chemical effect on the brain to make it less likely to seize. So I don't think it's the low fat or the high fat. I think you probably don't have to worry about that too much.
Carbs.
So let's move to the subject now of exercise. What exercises and what sports are you worried about you or your children doing because of your seizures? Anyone want to open their mic and make a comment on that? While you're thinking about that, I will repeat that several types of exercise were listed in the chat box as potentially helping seizures, maybe by reducing stress. Martial arts, Tai Chi, yoga was mentioned on several occasions. Just exercise in general as helping. But what exercise, sports, or recreations do you have concerns about or would like to discuss? Okay, I'm not hearing much about that. I would, for example, recommend against hang gliding, parachute jumping. I myself have not given a absolute prohibition against scuba diving if seizures are extremely under control, and if you scuba dive in a way that you have a buddy, which you always should, and can be brought to the surface quickly. But some of my colleagues don't agree with me on that. And in general, as neurologists, we're not too happy about any sport that traumatizes the brain or the spinal cord. I don't necessarily think that's a special issue for people with seizures. It's a fine balance, because you don't want to be overprotective and further stigmatize or isolate a child or even an adult, because recreation is so key. But you do want to look at the recreation, you want to look at the degree of seizure control, and you need to think about the danger of what might happen if a seizure occurred during that event. So Freya has a question about seizure types. What's the difference between a seizure that we have no recollection of and a seizure that we are aware of? Dr. Cornes?
Well, sometimes the seizures that you have no recollection of versus the seizures that you have an awareness of speaks to which parts of the brain are involved or how much of the brain is involved. So sometimes a seizure that is smaller, you might have a recollection of if a large part of your brain is functioning normally and capable of perceiving that change. For example, if you have a aura with tingling or a movement on one side of your body, you might be aware of that. If the seizure was to spread, what we would call a secondary generalization, perhaps, where it spreads throughout the brain, you might not remember the seizure. So sometimes it has to do with the extent, sometimes it has to do with which area was involved from the get-go. Is that answering your question adequately?
Sort of. Do you mind if I ask a little bit more?
Of course.
Okay, it's my son again, and we thought all of his seizures that he had no knowledge of until just recently, and now he's having, I call them involuntary hand movements, where it's like a synchronized hand movement, and he said the other day, oh, I know that I do that, I just can't control it. So this is the first awareness that I've had that he actually is aware of this seizure, and we thought he wasn't. So he has these kinds of seizures. He also has grand mals, where his whole body seizes, and the other day he had one where he was at a grocery store and walked to the back of the grocery store where no public would be allowed, and went to the back and opened up a cooler door and walked inside. And he had no recollection of this, but his body didn't seize.
I can take this one, Dr. Cornes. How old is your son?
22.
22. And has his seizure pattern changed over the years?
Yes, definitely.
Okay. So, go ahead.
He was diagnosed at 14.
Okay. So you're describing several different seizure types, and of course it's all really the same thing, and it depends mostly on how far through the brain the electrical storm of a seizure is spreading. It sounds as though some seizures are having a very local effect. When that happens, people can just have strange feelings or sensations. The temporal lobes, which is one of the four lobes, the one on the side of the brain under the ears, is the most seizure-prone structure of the brain. And temporal lobe seizures can produce those unusual feelings. They're sometimes called auras, like warnings of seizure. But if the abnormal electricity spreads to both temporal lobes, then a person can no longer lay down memory traces during the seizure because the seizure is involving the memory mechanisms. And behavior becomes very fragmented with what we call automatic behavior or automatisms, like these little Disney robots that do things over and over again. Walking into a room or an area you're not supposed to be, or fumbling with the hands would be automatisms. Usually when seizures have spread to both sides of the brain, people are not aware, they're not remembering, and most of the time when you have automatisms, you don't remember, but a few people do remember some of the automatisms. Now, if the seizure activity spreads to the entire brain, that's when you have what you call the grand mal seizure, with total loss of consciousness, with falling, stiffening, and shaking. So a lot depends upon where the seizure starts in the brain and how far it spreads. We're not talking today about seizure medicines, but one of the things seizure medicines can often do is limit the spread of seizures to a different part of the brain. So let's come back to diet. There's a good question about MSG, by which I assume Valerie means monosodium glutamate, and neuronal excitation. Glutamate is the main excitatory neurotransmitter in the brain that brain cells use to talk to each other. And if you were to put glutamate, or monosodium glutamate, which is a form of it, directly on brain tissue, you would start that brain cell firing very rapidly, and if that activity spread, you could indeed have a seizure. We have something called the blood-brain barrier, and that is designed to keep substances out of the brain, including monosodium glutamate. So with the exception of a few places that can get through, most of the brain is very well protected against monosodium glutamate. And it's the same answer, by the way, for some diet sweeteners like aspartame, which have aspartate as a metabolic product, the other main excitatory transmitter. The brain is really quite well protected against Diet Coke. So we're coming towards the end of our time. Let's see if we have time for a few more questions. Philip asked, were the patients in the Atkins or ketogenic diet on anti-seizure medications as well, or just purely on the diet?
They were on medications as well, and they tried to look at whether folks who stayed on the same medications the whole time or made medication adjustments did better or worse. It's very similar. Most people continued on with their regular care, their regular treatment. If their physician felt medications needed to be adjusted, they were adjusted. It's possible that medications for certain individuals may be able to be lowered if diets are incredibly successful. That would be something to talk about with your physician over time.
We'll take one more question, which is actually a question about epilepsy surgery rather than wellness per se. But Angie asks, would loss of the left amygdala and hippocampus in surgery make a difference to memory of seizures post-surgery? So I guess not a difference to memory in general, but would it affect whether you remember your seizures? I'll take a crack on that, and then you can comment. The amygdala, which is a Greek word meaning almond, looks like an almond, is involved in emotionality. The hippocampus is very much involved in forming and retrieving memories. So when you take hippocampus out, which is commonly done in epilepsy surgery because it is the most seizure-prone structure in the brain, there can be some memory side effects afterwards. This was the subject of our last month's Epilepsy iConnect at Home, is thinking in memory problems in epilepsy, including post-surgery. Fortunately, most of the time, memory does not get worse after taking the amygdala and the hippocampus out. Now, the specific question here, as I understand it, is does it affect the memory of memory during seizures? And I think the answer to that is yes, and in a happy way, because, well, first of all, you hope after surgery you have no seizures, but some people still do, and then you hope that they're much more mild than they were before. So since the seizures are more mild, you're going to be more likely to remember what's going on during those seizures than you would have with a preoperative stronger seizure. So in that sense, it can affect the memory of seizures post-surgery. Well, I see that we're at the top of the hour here, so that is our time. I'd like to thank Dr. Susannah Cornes of the UCSF, University of California, San Francisco Epilepsy Program, for presenting a stimulating and informative session, and for all of you for being a lively audience and sharing your experience and questions. Now, we transcribe these. We don't put your names in the transcription, and we also post them. So there will be a posting of the sessions and a transcription as well. And that takes a few weeks before it goes up. You'll be able to find it on the Epilepsy Foundation of Northern California website, a link, and you'll also be able in the near future to find it on YouTube. So thank you very much for coming, and that concludes our web broadcast. Bye-bye. See you at the next one.
Bye.